So blood pressure, this is just the force that is exerted on arterial walls by blood, and of course it's measured in millimeters of mercury. And the things that kind of play into blood pressure are the contraction strength of the left ventricle, how elastic the arteries are, any sort of peripheral resistance in the arteries, as well as the viscosity and the volume of blood. And we talked about how all of these can change in response to different lifestyle choices and pathology. Of course, the top number is the systolic number. That is the pressure during systole of the heart when the heart's beating. And then the bottom number is the diastolic number. This is the pressure within the artery when the heart's in diastole, when it's resting. The systolic minus diastolic pressures, this is known as the pulse pressure. Long-term blood pressure control, so blood pressure regulation. We do have a couple of short-term sort of solutions, but the big takeaway here, long-term blood pressure regulation occurs by the kidneys. We went through the whole RAS system in class again. I'm not going to ask you about it on this exam, but of course that's fair game for the final. So changes in perfusion. So we talked about ventilation perfusion matching. This is about ventilation perfusion mismatching. So again, we want the amount of oxygen we bring into the lungs, we want that to be roughly the same amount of oxygen we put into the blood. But there are cases where we can have perfusion without ventilation, meaning something is blocking the movement of air itself, but we still have the capacity to perfuse. This can occur in things like pulmonary edema or asthma. We can also have ventilation without perfusion, where we can move air without a problem, but perfusion, we can't move that oxygen into the blood or the CO2 into the lungs for some reason. And the good example of that's a pulmonary embolism. So changes in circulation. Hemorrhage, this of course is the loss of blood through a broken vessel wall. Thrombosis, this is the formation of a clot. And there are really three things that precipitate the formation of a clot. These are known as Virchow's triad, which includes excessive clotting, damage to the blood vessel wall, and also changes in blood flow, turbulence. So things like atherosclerosis are certainly things that would cause turbulence. Excessive clotting, so people have some genetic clotting disorders, but I talked about how people who smoke, of course, are hypercoagulable. And vessel wall damage, again, this occurs in people with hypertension, smokers, diabetics, all of those things. Now, if the thrombus breaks free, it's called a thromboembolus. Sometimes it's just called an embolus, but an embolus is a general term for anything that is traveling in the blood and can cause an obstruction. So an embolus could be a clot, a moving clot. It could be fat. It could be amniotic fluid. It could be a number of things. Air. All of those are considered emboli. Arteriosclerosis, this is the thickening and hardening of arterial walls. And atherosclerosis, this is I like to think of this as advanced stage arteriosclerosis. So this is more significant. And this is where you have an inflammatory response occurring in the blood vessel wall. And you get the formation of these plaques within the wall of the blood vessel. All of these injuries, arteriosclerosis, atherosclerosis, they begin with injury to the endothelium, which is the lining of these blood vessels. Things like smoking is very damaging to the endothelium. Hypertension, diabetes, those are all big causes of atherosclerosis. What happens with any injury in the body is it induces an inflammatory response. And then we bring immune cells, inflammatory cells, to the site. So macrophages will come in. They produce free radicals because that's what they do. That's what they do when they're trying to clean things up. However, unfortunately, when they produce these free radicals, they're not killing pathogens, but they're just damaging the blood vessel wall. And they also cause the oxidation of LDL. And LDL, low-density lipoprotein, it's probably there to deliver cholesterol to help the cells repair themselves. As more of these macrophages migrate into the intima, that's the tunica intima, which is that endothelial layer of the blood vessel, they will kind of consume this LDL that they oxidized. And when they consume those, they're called foam cells, because if you look at them under the microscope, they look foamy. They look like macrophages that are full of just like fat. And as these accumulate, you start to see these fatty streaks. You see these plaques build up within the wall of the vessel. And of course, these aren't good, especially if they form in the coronary arteries, because that could precipitate a heart attack. Or if this is in the the carotid arteries, this could precipitate a stroke. So it really is a significant medical condition. The thing is, these take a long time to develop. This does not happen overnight. So by the time people are diagnosed with this has been brewing for many years. Aneurysms, these are just outpocketings of a blood vessel wall, typically in reference to an artery. Aneurysms have never killed anybody, but when they rupture, they can certainly be dangerous. They commonly form in the abdominal aorta. They commonly form where the carotid artery bifurcates into the internal and external carotid arteries, and a couple of other places. Venous stasis, this is just the slow movement of blood in the veins, in the venous system. And you'll see this, people with varicose veins, it's typically not a huge issue, other than the cosmetic issue that people have with varicose veins. But that's still a form of venous stasis. That's because the valves in the veins have failed. Also, heart failure causes venous stasis, prolonged bed rest, all of those can cause venous stasis. Now, all of these things I've talked about, venous stasis, aneurysms, atherosclerosis, all promote thrombus formation. Okay, these are things that promote the formation of clots. And this is bad because, of course, if those clots get to moving, they can end up in the lungs if it's, lands in the right side of the heart, or it can end up in the brain if it's in the left side of the heart. So changes in cardiac output can be caused by quite a few things. Septal defects, so these are defects in the septa between either the atria or the ventricles or both, and what happens is you have the commingling of blood. Oxygenated, deoxygenated blood is mixing together, and that's not good for obvious reasons. You can also have defects in the heart valves. Most commonly in the aortic and the mitral valves, you can have stenosis, which is a narrowing, a hardening of these valves. Regurgitation, this is where you have blood flowing in a retrograde fashion. It's going backwards, and that's not good. Cardiac dysrhythmias, there's a ton of these cardiac dysrhythmias or arrhythmias, and these are electrical disturbances in the heart. They're dangerous when they change how the atria and the ventricles communicate with each other. And a heart block, this is an obstruction somewhere in the cardiac conduction system. Typically occurs most often in the AV node, which is an AV block. Sometimes it's noticeable, sometimes it's not. So here's just a couple of examples. This is a septal defect in the atria. This is known as a patent foraminal valve. There's one in the ventricles. This is just a couple of examples. There are other possibilities also. And then here we have stenosis of tricuspid valve. So the disease is hypertension. This is elevation of systemic arterial pressure. I believe it's 130 over 90 now. Used to be 140 over 90. There are a couple of types. There's primary hypertension, which is the vast majority of cases. Primary hypertension, essential hypertension, idiopathic hypertension all mean the same thing. You should be familiar with those three names. But again, this is by far the most common. It's a multifactorial disease, so it does not occur in response to any other disease. Risk factors, smoking, of course, high sodium intake, obesity, family history, age, all of those things that we are familiar with. Secondary hypertension, this occurs in response to another disease. You see this with kidney diseases. Sometimes, if you have like an adrenal cortex tumor or really any tumor of the adrenal gland can cause changes in epinephrine output and aldosterone output. So there's a number of things that can cause secondary hypertension, but it's quite rare. So clinical manifestations of hypertension, typically none, at least early on, but as it continues, people may see changes in vision, heart disease, because the heart is working harder to push against this greater pressure, problems with the kidneys, but these are chronic complications of hypertension that's pretty much been untreated or poorly treated. So as far as treatment, lifestyle modifications can take people a long way. I'm going to say that about pretty much any disease. But of course, all the typical players here when it comes to the drugs, so ACE inhibitors, ARB blockers, beta blockers, diuretics, all of those are used very commonly. Then here's just a sign. Diagnosis, ideally should use readings, multiple readings over a 3 to 6 month period. Unfortunately, those recommendations aren't always followed. So a heart attack, this is known clinically as a myocardial infarction or an MI. This is where you have death of these cardiac myocytes due to an interruption of blood flow to the myocardium. Most often caused by atherosclerosis of the coronary arteries, which is coronary artery disease, CAD. And what happens is these cardiac myocytes, they do not have oxygen, they start to die. One by one, they undergo apoptosis, and as this continues and continues and continues, the site of infarction becomes greater and you have necrosis. The problem here is when you have death, you have the necrosis of these cells, you interrupt the conduction of the heart, the conduction system. And this is what can kill. This is when you get these life-threatening dysrhythmias. Now, if you survive, these cells will degrade, fibroblasts will come in, and they will lay down scar tissue. And this can cause problems later on in life when it comes to conduction system in the heart, so you may have problems with arrhythmias and dysrhythmias later on. Clinical manifestations, sweating, that sudden crushing chest pain that is referred to the jaw or the shoulder, sometimes nausea, vomiting, sometimes just the feeling that something's not right. Complications, the most severe is sudden cardiac death, which is due to that interruption of the conduction system. Electrical instability, which can come early on or later on. Dysfunction of the left ventricle, which can lead to heart failure. So there are certainly complications if you're lucky enough to survive a heart attack. So diagnosis, EKG, history, exam, and of course troponin. You'll see increased troponin levels, which is a protein that will be released from these dead cells. Treatment, administration of aspirin, blood thinners, antithrombotics, PCI. You will use this mostly for STEMI cases where you have an ST elevation, myocardial infarction. That's basically a cath. But if that's unavailable at the moment, you would give a thrombolytic to try to break up the clot as quickly as possible. So here you can see, if the severity of the heart attack really depends on where it occurs. If it occurs way up here, high up in the coronary arteries, you're going to have a much more significant pathology. If it occurs down here in these smaller areas, you might not have such a tough road ahead. Here, all of this is dead. This is all necrotic heart tissue. Pretty significant. This is probably what killed this person. Okay, stroke or cerebrovascular accident. There are ischemic types and hemorrhagic types. The ischemic types, this is when there's some obstruction. Maybe it's a thrombus that formed within an artery supplying an area of the brain, or maybe an embolus that originated from the left side of the heart, got lodged in a blood vessel in the brain. Hemorrhagic, these are often due to cerebral aneurysms that have ruptured. Both cases are going to result in decreased blood flow to the brain. The hemorrhagic types will also increase the intracranial pressure. So risk factors, hypertension, smoking of course, number one risk factor, diabetes, increases in the number of red blood cells, which is polycythemia. That makes a person hypercoagulable, as well as AFib. And we talked about AFib. If the atria are fluttering, that blood is kind of sloshing around, and that promotes the formation of clots. If you form a clot on the right side, that can go to the lungs. If it's formed on the left side, it can go out to the body, including the brain, which can cause a stroke. TIAs, transient ischemic attacks, these are mini strokes, and I call these your get-out-of-jail-free card because they might serve as a possible warning to something bigger, like a stroke. But basically, these are short-lived neurologic symptoms, typically lasting less than an hour, has to resolve within 24 hours to be a true TIA. Clinical manifestations, you'll have the contralateral motor and sensory deficits, numbness, paresia, ataxia, problems walking, confusion, problems speaking, dysphagia, dizziness. I use the little acronym in class, the FAST, face, arm, speech, and time. That's what you would, and again, it really depends on where the stroke is occurring as far as these manifestations, but these are kind of the general ones. Okay, then we talked about heart failure, and this is just when the heart is no longer able to pump blood effectively to meet the demands of the body. Risk factors, hypertension, of course, but also ischemic heart disease. So if people have coronary artery disease where blood flow is not getting to the heart, or they have history of heart attacks, those are certainly risk factors for heart failure. Obesity, problems with the kidneys, age, some congenital heart defects can cause heart failure, valvular issues can cause heart failure. There's lots of things. It can be a side effect of medication. The list kind of goes on. Now, you can classify heart failure as acute and chronic, systolic, diastolic, but we're just going to talk about left-sided and right-sided heart failure. Again, right-sided heart failure most often is the result of left-sided heart failure, but they can occur separately. So, left-sided heart failure, also known as congestive heart failure. Sometimes CHF is used just to describe heart failure in general, but we'll just call it left-sided heart failure. So what happens is you have increased preload, increased end diastolic volume. And this is because the heart, for some reason, just can't quite keep up. It's starting to fail. And as you increase the end diastolic volume in the ventricle, left ventricle, it starts to stretch. And I showed you that curve, okay? So if we have this here, this little curve that I showed you, and I did this here, we want to be about right here. So if this is stretch and this is contraction strength, it doesn't matter which axis it's on. As the heart stretches, it actually contracts more strongly, but only for a bit. Okay, once you start to get over this hill, it starts to get weaker and weaker and weaker. And that's the problem with heart failure, is you get over that hill, and it's hard to get back over that hill. And in most cases, you can't. So as the ventricular wall is stretched and its function decreases, blood starts to back up. Okay, remember, the left side of the heart receives blood from the lungs. So as it's failing, blood is starting to back up into the left atrium, into the pulmonary veins, back into the lungs. And, patients will have dyspnea, especially upon exertion, but not always just exertional. Orthostatic hypotension, so drops in blood pressures upon standing, decreased pulse pressure, decreased peripheral pulses, and as this gets worse and worse and worse, you have pulmonary edema. Because that blood is backing up into these pulmonary capillaries, it's pushing fluid out. It's increasing that capillary hydrostatic pressure within the lungs. So you have pulmonary edema, which of course is worse upon lying. So the right ventricle is then going to start to get involved because as this blood is backing up into the lungs from the left side, the right side, which pumps blood to the lungs, is having to work harder because it's pumping against all of this resistance in the lungs. And that's what's going to precipitate its failure in most cases. So left-sided heart failure, again, these are all of the kind of the manifestations. Some of the big ones here, though, is pulmonary edema. That's really characteristic of left-sided heart failure as it gets worse. And then right-sided heart failure. So again, this right ventricle is starting to enlarge because it has to push against this greater pressure in the lungs, and this reduces its function. You have tachycardia, decreases in cardiac output, palpitations, but also we're going to have increases in central venous pressure. All right. And this is going to increase pressure in the visceral veins like the hepatic portal vein. And this is going to cause congestion in the liver, so you can have problems with the liver at this point. You will also see jugular vein distension, because remember, the right side is receiving blood from the body. Okay, so when it's receiving blood from the body, but it's failing, it's not pumping blood out as efficiently, it's starting to back up also. And on the left side, blood backed up into the lungs. On the right side, blood's going to back up into the system. So that's why you'll see distension of the jugular veins. You'll see this increased central venous pressure in regards to the hepatic portal vein. But also, as it continues to back up into the system, this increases capillary hydrostatic pressure in the system, and this is going to push fluid out, and you see this pitting edema in the lower extremities. That's kind of characteristic of right-sided heart failure. So manifestations here, clinical symptom or evaluation. Diagnosis, history, clinical symptoms, an echocardiogram, chest x-rays, you'll see the enlargement. lab tests like stress tests and things like that. As far as treatment, you want to increase how efficiently the heart pumps and preventing further failure. So when I show you that curve, you basically want to stop going down that hill. That's kind of the goal of treatment. So as far as kind of quick and dirty types of ways to treat it, diuretics to remove fluid as quickly as possible. So if somebody has pulmonary edema, that has to be treated. Bed rest, digoxin, which is going to increase the contractile strength of the heart. Compression stockings for edema, trying to move that fluid back into the circulation. Vasodilators, and like I said, pulmonary edema has to be treated. Again, right-side heart failure, you have this congestion in the tissues, in the system, and that's where you see problems with the liver because of that increased central venous pressure. You'll see edema, ascites because of that pressure in those visceral veins, very, very similar to what you see with cirrhosis. Although they're different, they are related. So those are kind of the big takeaways for right-side failure. As always, if you have any questions, please let me know.